Good morning. My name is Scott Morgan. I'm a radiation oncologist at the Ottawa Hospital, and I'd like to begin by thanking Larry and Jennifer and Dr. Morash for the invitation today. It's a real privilege to be here in front of this group, who I imagine all of whom, or nearly all of whom, has been touched in one way or another by this disease. Chris had asked me, if we can get my slides loaded, to talk about the current status, sort of the current standard of care pertaining to radiotherapy, and also some future directions. Only got 10 minutes, so I've had to be a bit selective about the topics that I'm going to touch on. And here we are. So what I'd like to talk about first of all is sort of the current innovations that have made their way into radiotherapy practice in prostate cancer in the past few years. There's been a move that's in progress towards fewer treatments for primary treatment of prostate cancer, and I think that has advantages for patient convenience and resource allocation in our healthcare system. I'm going to talk a bit about some new data. I'm not going to have a data-laden talk. Chris asked me not to do that, but I've got a few pieces of data that I couldn't resist sharing with you on comparative effectiveness of radiation and surgery. About some combinations of radiotherapy with new systemic treatments. Dr. Keneal will talk about systemic treatments in detail, but I'd like to talk about them just as it pertains to localized cancer. And then finally, a future direction about using precision radiotherapy in men with advanced cancers. So radiotherapy is really radiation oncology in general is really a high technology domain within medicine, and I think as computing improves, as imaging improves, so too does radiotherapy. So if we could draw a parallel with, say, over how the last 20 or 30 years mobile phone technology has changed. We go back to the mid-'80s. On the left there, you can't see it very well, but we've got the cell phone that's packed into a briefcase that CEOs used to pack around back in the '80s. And we've moved years later into around 2000, we got the little Nokia phone, which is a lot smaller, but still a phone. And now the iPhone computer in your pocket of 2017. In the same way, radiotherapy has changed a great deal over the same period. If you go back to the '80s and '90s, we were using really plain X-rays to plan radiotherapy for men with prostate cancer. So this is the sort of X-ray that would have been used to plan radiotherapy at that time. I defy you to try to find the prostate in there. It's completely invisible. A big step forward was moving to using CT scans to plan radiotherapy. And that was about 15 years ago, and that allowed us to visualize the prostate better. But our techniques were really limited in terms of how to deliver the prostate, deliver radiotherapy to the prostate, and there was a lot of radiation dose delivered to the rectum as well. And we've moved forward in some respects, still have a lot of way to go, but now in 2017 we have arc therapy that allows us to more precisely and uniformly deliver radiotherapy to the gland. So this, here's a picture of a linear accelerator. These are sort of the workhorses of radiation oncology departments. We've got a number of exactly this model in our department at the Ottawa Hospital. And essentially, this is what allows us to deliver high-energy X-rays, photons, in a precise way to the prostate gland. This is the treatment head, or the gantry, and the photons or the X-rays are directed in this way. And the gantry has the ability to move in an arc. You can sort of visualize that here, that it moves in an arc, and as it's moving around the patient, the beam aperture is changing at all times, and it basically allows for precise delivery of radiotherapy to the target. There's also, you can see here, at 90 degrees to the treatment unit, there's an imaging panel, and that's an advance as well. It's what's called image-guided radiotherapy, and that essentially allows for an image to be taken immediately prior to treatment to allow for precise alignment of the patient. And that's really something we've only had for about the last 5 years. So this is a patient recently treated of mine, and this is what we call in the parlance of radiation oncology an isodose distribution. You can think of it as like a topographic map or a heat map. Essentially what it is the areas of the same color here are of the same radiation dose. And you can see the outline here of the prostate, and then we have another green expansion around that, which is the area we treat for security in case there are cells that have escaped beyond the gland, and also to allow for differences in patient motion over the course of the treatment. Now you can see here, here's the rectum. This is the critical normal tissue that we want to minimize radiation dose to. And you can see that even with our current techniques, there is still some parts of the front of the rectum in the high dose region. So what is being done to try to move this forward? One thing that we're quite excited about, although it's not yet, it has entered routine practice in Canada, is a spacer, a hydrogel spacer, which can be inserted into the space between the prostate and the rectum to sort of increase that distance, and so to allow for the high-dose radiation region to spill not into the rectum but into this spacer. It's a hydrogel that gets inserted in much the same way as a brachytherapy procedure is done into that space between the rectum and the prostate. So it expands that space. You can see it here on an MRI. In the middle here is the spacer. And it's an inert substance that over months sort of is absorbed by the body. By 6 months post implantation of the gel, you can see here, sort of the pointer's not working, the lower right, 6 months later the gel has been absorbed. So I know this is now approved by Health Canada and funding's been applied for with Cancer Care Ontario, so we hope to introduce this into our practice soon, and it's a way of not improving efficacy but reducing side effects. Another evolution has been simply in the number of treatments that are given for a course of radiotherapy for men with localized prostate cancer. Traditionally, radiotherapy has been given in very small fractions over several weeks, and that's not limited to prostate cancer, it's for other cancers as well. And up until last year, our standard in Ottawa was to give each of those little red arrows represents a single treatment. And up until last year, we were delivering courses of radiotherapy Monday to Friday, 38 treatments over 7.5 weeks. Quite a long course of treatment and fairly inconvenient for patients, especially those traveling from a distance. So there have been a number of studies, and my conviction, like Dr. Bose, is that really our clinical practice needs to be guided by research evidence from well-conducted trials. There have been a number of trials that have compared the conventional schedule with an abbreviated schedule of 4 weeks, and the arrows are a bit bigger here, representing a little bit more dose per treatment. And these studies have been done in Canada, the United States, in Europe, about 6 or 7 of them, and essentially they have shown equal effectiveness of the shorter schedule without increasing late side effects from a urinary or bowel point of view. So that has been adopted in Ottawa over the last year. I think nearly 100 men in our cancer center have received this 4-week schedule. And then finally, perhaps what represents the future is a movement to even fewer but larger doses of radiotherapy, perhaps as few as 5 treatments, larger treatments given over perhaps a 2-week schedule. And so the trial that we are currently taking part in, have recently opened, is something called the PACE trial, and I want to recognize the Ride for Dad and the Prostate Cure Foundation for supporting our efforts on this trial locally. And patients now have, just as of the last month, an opportunity to take part in this study, which is comparing these 2 treatment strategies in a randomized way. Very briefly, for the longest time, we really had no high-quality evidence comparing surgery and radiotherapy in localized prostate cancer. And now in the last year, there's been what is really a Herculean effort in the UK. It's been 15 years in the making of a study which compared in a randomized way, so in a very well-balanced way, surgery with radiotherapy and active monitoring. Now they had to approach nearly 200,000 men in the UK, and ultimately it was initially a PSA screening trial, like Dr. Kajianis was referring to. But those men who by PSA screening had a prostate cancer diagnosed were invited to participate in a study comparing these 3 treatment approaches. And as of the last year, we have results from this study. This is a slide which shows the proportion of men that are free of progression. And it looks like there's only 2 curves there. So the higher the curve, the larger the proportion of men that are free of their cancer progressing. Looks like there's only 2 curves, and that's really because the surgery and radiotherapy curves are superimposed, they're overlapping. So there was really no difference in the freedom from progression in those who had either surgery or radiotherapy, whereas there was a higher proportion of men who had been actively monitored who did have progression. Now this study has limitations, and I think the chief limitation is that many of the patients in this study had quite low risk cancer, and I think most of us would now recommend that they not have received treatment. But there's a substantial minority of patients who did have intermediate risk cancers for which we really would recommend treatment, and we're not seeing really a difference in outcomes between radiotherapy and surgery. So at 10 years of follow-up, quite long follow-up, no difference in rates of recurrence. Another exciting area, Dr. Keneal is going to talk, I'm not going to steal her thunder, but she's going to be talking about the new systemic therapies that are available to us for advanced prostate cancer. And they're eventually moving earlier in the disease course, and we're going to be able to look at offering them to men with localized cancers with the aim of trying to improve cure. So just to take you through how a man whose cancer, unfortunately, despite our best efforts, recurs, the trajectory that he might take, at time of diagnosis might receive either primary surgery or radiotherapy, and then if recurrence happens, PSA starts to rise, may receive salvage local therapy, for example, radiotherapy after surgery to try to secondarily cure the cancer. If that fails, and hormonal therapy is often started, and there can be evidence of cancer elsewhere on the body. Now, hormonal therapy can often control the cancer for many, many years, but inevitably resistance to it develops, and at that point, chemotherapy is often used. So the new therapies that have been evaluated or studied in prostate cancer have typically followed this course. They've been studied initially at the very most advanced phase. Why? Because that's where the unmet need is greatest, and that's where, frankly, the benefit or lack of benefit of therapy can be found out, ascertained more quickly. If a therapy has been shown to be effective at the very advanced stages, it tends to be moved earlier, and in the case of the new systemic therapies, it's been moved prior to chemotherapy, and some of these therapies have been shown to be effective there. However, the most exciting thing from my point of view as a radiation oncologist is the potential for using some of these new therapies upfront at time of diagnosis, because that is the time where we have the potential to increase rates of cure. Instead of just prolonging control of disease, actually saving lives, improving rates of cure. And so another piece of data here, but to me this is the most exciting survival curve I have seen this year as a radiation oncologist, and that is a study which looked at a new form of hormonal therapy, abiraterone. Dr. Keneal, I'm sure, will discuss this, in men who had localized prostate cancer, very high-risk localized prostate cancer, who were receiving the current standard of care of radiotherapy and hormonal therapy, and half of them, in addition, received the new therapy. And the difference between these two curves is what gets us excited. So these are the chances of being free of recurrence years down the road. And you can see that in men getting the combination of radiotherapy, standard hormonal therapy, and abiraterone, only perhaps 5 to 10% of them having recurrence by 4 years down the road versus about 35% with their standard. So a big jump forward. We don't yet have mature enough data to have this enter clinical practice, nor is it funded, but to me this is the way of the future for radiotherapy. And then finally, I just want to talk about how precision radiotherapy might have a role to play in men with cancers that have spread elsewhere and have spread in a limited extent. So Dr. Lavallee mentioned the new imaging modalities that we have at our disposal now, and really the message here is that we will be discovering, with more sensitive imaging modalities, smaller and smaller foci of cancer spread at an earlier stage. So what we declare now to be just a rising PSA, we might, with more sensitive image, actually find very focused and limited sites of cancer spread. And that raises the question as to whether there might be a role for focused radiotherapy to those sites of spread. This is just a standard bone scan and then standard CT scans, and what they're trying to illustrate here is that a site of cancer spread here in the pelvis was missed on the standard bone scan and CT scans. So we do have a modality which allows us to deliver radiotherapy in a very precise way. It's something called stereotactic body radiotherapy. There's a number of different commercial platforms available. We're lucky in Ottawa to have something called the CyberKnife, which is along the theme of Dr. Morash's talk, a robotic form of radiotherapy. So it's essentially a linear accelerator mounted on a robot which can move, can sort of translate in all three directions, and can rotate about all three axes, and so it can deliver radiotherapy from any number of different angles, and it allows for radiotherapy to deliver in a very focused way. So I'm just going to share with you a case from my own practice to finish of a way in which this might have a role to play. So, and this gentleman knows that I'll be presenting his case and consented to it. So this is a 61-year-old man. He's extremely fit. He's a triathlete. And he, back in 2012, underwent a radical prostatectomy and was found to have a fairly pathologically advanced prostate cancer invading the seminal vesicles. About a year and a half or 2 years after that, unfortunately, his PSA started to rise from an undetectable level. He was treated with salvage radiotherapy in 2014, and unfortunately about a year and a half or 2 years later, his PSA started to rise again. And we did a number of imaging tests. We did a bone scan, we did a CAT scan of his chest and abdomen and his pelvis, and we also did an MRI of his skeleton. And they identified a single area of cancer spread in one of the vertebrae in the middle of the back. You can see it here on the MRI. He was very keen to avoid the use of hormonal therapies, a triathlete, and he was concerned about some of the potential side effects. So we discussed his case at our weekly rounds where we discussed difficult and challenging cases. The standard treatment here, no doubt, would be hormonal therapy, but he had reservations about it, and so we felt this was amenable to stereotactic radiotherapy, and so he was indeed treated on the CyberKnife back in July of 2016. You can see again here the Isodose distribution, and again this is like a topographic map, and as you move away from the vertebra you can see these lines are very close together. There's a rapid drop off in radiation dose as one moves away, and that's the advantage of the CyberKnife. You can see that in another orientation here, and these are all the various beam angles that the robot is delivering the radiation from here on the lower right. And I'm pleased to say, a year later, I saw him last month, his PSA is now down to 0.05 and he's off of hormonal therapy. Now we expect over time that his cancer is likely to disseminate to other places, but at least he's had a year free of hormonal therapy. And this is a technique that requires further study. And in fact, Dr. Bro and I were just, will be part of a collaboration across Canada that is looking at a rigorous study of just this sort of therapy in prostate cancer that is spread to a limited basis. So I thank you for your attention.